Hello everyone, I am Dr. Apoorva Pandit, an executive committee member and head of the social media subcommittee of KCIAPM. Today, it's our privilege to have Dr. Vani Santosh ma'am, a distinguished neuropathologist with decades of experience in diagnostics, research and teaching. She has served as senior professor at NIMHANS and Dean of Neurosciences at NIMHANS and is currently working as senior consultant at Aster Medcity and visiting professor at NIMHANS. Beyond her immense contributions to patient care, she has played a major role in shaping neuropathology education and research in India as well as abroad. We are truly honored to have her here. Thank you for taking the time to speak with me. To begin with, what drew you towards the field of pathology, specifically neuropathology?
Good morning, Dr. Apoorva, and thank you for having me here to be engaged in a conversation with you for PathVarna from the KCIAPM. Certainly a great pleasure and an honor for me. So to answer your question, my MBBS training has been from the Bangalore Medical College and so also my MD training. And during my undergraduate training, particularly during my second and my third year of training, I was very intrigued by pathology, particularly histopathology, because I felt that it revealed hidden secrets behind diseases. And I was extremely impressed by that, and when I looked into the microscope, I almost felt that the cells were talking to me. And during those days, I was quite a voracious reader of fiction. Oh. And I read this very famous novel, all of you must have read, The Final Diagnosis. It is by Arthur Haley and published way back in 1959. And it talks about this young next-gen pathologist who wants to bring in credibility, wants to bring in changes, reforms in the lab practices in order to improve diagnostic accuracy, and the challenges that he faces during his, his tenure over there. So it was a lovely book, and I was very impressed by that. And then I said, I was young, and then I said, okay, I will do my, I'll pursue my post-graduation in pathology, and that's how I went into MD pathology. Now after graduation, I didn't want to just be a general pathologist. I wanted to super specialize, and there were two super specialities that I was interested in. One is molecular pathology and the other was neuropathology. And during those days, I did get a chance to go to NIMHANS, the Department of Neuropathology. And when I saw that the way the faculty worked there, their ethos, their dedication, their commitment, I was so impressed with that. And I said, this is the field I should learn something about. So I started researching on neuropathology at that time. And I realized that neuropathology is a subject which has broad applications across disciplines, clinical as well as research disciplines. And as a clinical subject, it defines diseases of the nervous system. And through macroscopic, microscopic or even ultrastructural examination of biopsied and autopsy tissue. And as a subject, although it is deeply rooted in general pathology, let me tell you that neuropathology has developed in a different way. And because of its seminal connections with both clinical as well as basic neurosciences. So you can't really do neuropathology without that clinical background, without that clinical information. It is very important, particularly for nerve biopsies, muscle biopsies. So it's developed in a different way when compared to other branches of pathology. So I was very much interested in getting into neuropathology at that point of time.
Looking back to your MBBS, MD days, any specific incident or a mentor during your UG or PG or even super specialty that made you very comfortable with the field, that made you very interested in this field?
So to be very frank with you, I didn't have a mentor really during my MD days, and I was quite clueless at that point of time as to what I wanted to do. But I'm very thankful to my husband, Dr. Santosh Kumar. He is a pediatrician of more than 45 years of standing clinical practice.
Wonderful.
And during those days, he used to see a lot of pediatric neurology cases and developmental disorders, because pediatric neurology was not really very well developed during those days. And most patients used to go to pediatricians. And at that time, he would always tell me, look, I wish you take up neuropathology and understand the pathology behind all these diseases, because it's so interesting. Now already I was one step into that neuropathology, and he encouraged me further, and I think I don't regret that decision. Till date, I don't regret that decision.
So, as you said, your husband was the biggest support.
He was the
pillar.
biggest influence in my life and support for me during those days, and I'm very thankful for that.
Neuropathology is a highly demanding specialty. How did you find the time to balance all of your administrative duties, pathology related work, and even family in this field?
Well, that's a very difficult question. So, you know, let me go back and tell you a little history about how I got into neuropathology and how I got interested and how I settled down in neuropathology. So, I joined the Department of Neuropathology way back in 1989 as a senior resident. At that time, there were no courses over there, so we were non-course senior residents.
Okay.
So, I joined as a senior resident in the department, and Professor Sarla Das, she was the head of the department, and then Professor Shankar was the senior professor.
Okay.
He's, unfortunately, we lost him a couple of years ago. And Dr. Shankar first asked me that what aspect of neuropathology are you interested in, neoplastic or non-neoplastic? And I had no clue. I didn't know in which one would interest me. So I said, sir, I'll have to work here for some time and then decide. So he said, all right, but have you done autopsies?
Oh.
So I did tell him that during our MD training, we were exposed to autopsies because of forensic postings. But I really didn't have a hands-on experience, a good hands-on experience in autopsies. And I told him that I was willing to learn. So he was very happy with that, and so my training started with that. And during those days, we used to have a lot of clinical autopsies. You know, more than 350 to 375 cases per year. And I used to go to the mortuary almost every day to perform these autopsies as a senior resident. And initially, Dr. Shankar taught us very beautifully how to remove the brain, because most autopsies were limited to the removal of the brain. And we also had a technician there, Vishwambaram, now very fondly called as Mr. Mani, who taught all of us, you know, very perfectly how to remove the brain and how to fix the brain and things like that. Then I assisted the faculty in brain cutting. We used to have about every Tuesday we had a brain cutting where all clinicians would come, radiologists, paraclinical specialities. So it was all very crowded during those days, and it was almost like every Tuesday you have CPCs, you know, it was something like that. Very interesting, and I found it extremely interesting. And subsequently, I also assisted faculty for surgical sign-outs and did grossing, all other duties that a senior resident does. And we had Dr. Vasudev Rao and Dr. Asha, who were all very excellent in neuropathology. I think I learnt a lot from them. I really didn't want to move out of neuropathology. Now at that point of time, during the end of my training, there was no post open for me over there.
Oh.
So Professor Sarla Das told, and it turned out that there was a position that opened up in Kidwai Memorial Institute of Oncology for a lecturer's post in oncopathology. So she said, why don't you apply there? You anyway have so much of experience and you may be a good fit over there. But I was so interested in neuropathology, I didn't want to move out. And with her permission, I continued my residency for another year. And lo and behold, a position opened up. And I got into the faculty in the year 1993. And of course, I've been there ever since then, till my retirement in 2022, when I superannuated. I think NIMHANS has given me a lot. I mean, I owe everything. Whatever I've done there at NIMHANS, my clinical diagnostics, teaching, research, and what I have achieved, I owe it all to NIMHANS. And what I am today, also I owe it to NIMHANS. I had a lot of family support. My husband was extremely supportive of my career, and he was very proud of me that I was doing well during my tenure as a faculty as NIMHANS, and whatever encouragement was required was given to me in the family. And looking at both of us work very hard, I think my son got into that hard working kind of a routine, because me and my husband used to work very hard throughout our career. And so I think it was a little difficult sometimes to balance work and family life, but most often it was not really.
From surgical disciplines, do students or teaching faculty or clinicians themselves come to you with doubts about the pathology reports that are signed out, or their diagnostic related doubts? How do you explain this to them, or how do you go about it?
Oh, they do come back to you. They'll come back to every pathologist,
Yeah.
I think. Yeah, particularly if our diagnosis doesn't match their clinical or their radiological diagnosis.
Yeah.
So they'll come back to you and ask you, I mean, your diagnosis is different, and how do you explain that? What are we to do with the patient? Because we have to treat that patient. Well, you know, I've had these situations quite often, particularly in brain tumors, and I explain it twofold.
Oh,
One is patient related complexity,
okay.
and one is tissue related complexity. So what do we mean by patient related complexity? Whatever the pathological lesion we saw could be an atypical presentation of what they saw. Okay. For example, we know that in the base of the brain you can have this en plaque meningiomas.
Yes.
They're diffuse in the dura. But recently I had a case where they thought that it was an en plaque meningioma, sent it to me, a firm lesion, dural based, and it turned out to be an aspergilloma.
Oh.
Because aspergillomas are known to occur over there, and they're known to have this en plaque kind of a spread, and they are firm fibrotic lesions, and they resemble meningiomas. And in fact, we've written a very nice review article, all the faculty in the Department of Neuropathology along with some clinicians. We wrote this way back in 2010, infections and infectious lesions mimicking CNS neoplasms.
Oh.
So we wrote that, and those who are interested can see it was published in seminars in diagnostic pathology. So atypical presentations is something that we have to be aware of, and we have to educate the clinician about it as well. The second patient related complexity is if there are comorbidities or treatment related changes. You see, I'll give you one example. The example is primary CNS lymphomas. These are deep seated lesions in the brain, and when these are all primary and they're not metastasizing lymphomas, and these patients usually are treated with steroids to begin with itself. Upfront they are treated with steroids, and we know that steroid is a lympholytic agent, and the cells get quite crushed. The cells become very small, they look like reactive cells. In addition to that, there is an infiltration by reactive T cells. Most of them are B cell lymphomas, and there is infiltration by reactive T cells, there is infiltration by histiocytes. So you don't see that picture of lymphoma at all, and close differential diagnosis will be an inflammatory lesion, and one of the inflammatory lesions that mimics is a demyelinating lesion, which has similar morphology. But then the clinician will come back and tell you that, look, the older patient, and then we did MR spectroscopy, choline peak was very high, so we think it's a neoplastic lesion. So I'll explain to them that, look, steroid can alter the histomorphology. So you stop steroids and rebiopsy after a couple of months, and maybe then we would see the actual pathology. So these two are the patient related complexities, but we have tissue related complexity as well. So what do we mean by that? When they take stereotactic biopsies of deep seated lesions, whether they are gliomas, lymphomas, metastasis, particularly in gliomas, they might not have hit the lesion. The trajectory might have been a little away from that, and it may be an infiltrating zone of a diffuse glioma.
Okay.
And if it is an infiltrating zone, we see very few cells over there. They would have looked at the clinical profile, the radiology, it's a high grade glioma, maybe a glioblastoma, but then we are saying that there are few neoplastic glial cells. We cannot characterize further, and we cannot grade it further. So this is one tissue complexity we should keep in mind.
Yes.
And the other tissue complexity is the heterogeneity of the tumor itself. The tumor can have different grades within, particularly in gliomas. You see low grade areas, high grade areas. So if the biopsy is from that low grade area, it might not represent the whole tumor. So these are some things that we have to explain to the clinician, and I think over a period of time, at least at NIMHANS, they're very well aware of all these caveats and nuances when they do the biopsies, and they get back to us. And the bottom line of all these things is to have a dialogue with the clinician. So everything will be solved if you have a dialogue with the clinician. Because most clinicians, they don't come to the pathologist to have a dialogue. And pathologists want to sign out the reports. Whether it's neuropathology or any other aspect of systemic pathology, I would suggest that the pathologist has a dialogue with the clinician.
Communication
is the most important for histopathology.
Wonderful. Patient-related complexities and tissue-related complexities. Very well put, ma'am. I have never thought of it that way.
Yeah.
So, of all your work in glioma and molecular pathology, which was the hardest and most fulfilling?
Which was the hardest and most fulfilling?
Might not be the same.
Yeah, hardest and fulfilling is. First, we'll talk about the hardest, and then we'll talk about fulfilling.
Yes. Sure.
So the hardest, I mean, for me in my career was starting. See, I've been a diagnostician of long-standing experience. I've been a teacher, and then I've been a researcher. Okay, and that is the mandate of NIMHANS. Threefold mandate of NIMHANS. Service, you may be diagnostic services or treatment-related services, teaching and research. That is the mandate of NIMHANS, and all of us are followed that mandate. I am not saying it's just me, all other faculty as well. So, but starting research has been very challenging. You see. So, when I started my career, I was interested in studying brain tumors. I mean, I got into it, and then I said, this is where I have to be, and I have to analyze these brain tumors. But you know, I didn't have much experience how to go about it, and I didn't have the funding. So at that point of time, I approached Professor KVR Shastri. He was the head of the Department of Neurosurgery at NIMHANS. Very encouraging person. And he told me that, look, you don't have to have any funding to begin with. Just start analyzing groups of tumors. You can work with some of our younger faculty, you can work with some of the residents, and we'll analyze groups of tumors, the pathology and the clinical aspect, and we'll see what comes out of it. And if we get good results, we'll publish. And lo and behold, we published several papers with that. But the big break came for me in the year 2001-2002, when Dr. A.S. Hegde, he was the head of the Department of Neurosurgery at Satya Sai Institute of Higher Medical Sciences. He was earlier at NIMHANS and he knew me. He and his wife, Dr. Sridevi Hegde, they were a part of a very big multi-institutional collaborative project. And this was called, it was funded by CSIR, called NIMITLI. NIMITLI is New Millennium Industrial Technology and Leadership Initiative. And the other partners were from Jawaharlal Nehru Center for Advanced Scientific Research, that is JNCASR. It was Professor M.R.S. Rao. Unfortunately, we lost him also a couple of years ago. He was the team leader. And molecular biologists from Indian Institute of Science, Professor Kondaya and Professor Kumaravel Somasundaram. Now, what was that project? That project was to identify novel biomarkers in glioblastoma of clinical importance using high throughput technology. They were doing a lot of gene expression profiling experiments at that point of time. But they needed a nodal pathologist, a neuropathologist, who could bring it down from research to the tissue to the patient. And I was that nodal pathologist. They recognized me as that, and they approached me to get into the project, and I thought that was a great opportunity. I just plunged into that, and ever since that I've been with that group, and we've done a lot of work together. First we were funded by CSR and CSIR, subsequently by DBT. We even established the Center for Center of Excellence for Molecular Neuro-Oncology. And what I did in that project was, which is now fulfilling for me. You're asking me what is fulfilling for you. So what was fulfilling for me was I validated all the discovered biomarkers. So I validated it on the tissues, a retrospective cohort, and then correlated with tissue findings, correlated with the pathology, correlated it with the clinical profile of the patient's prognosis, therapy aspects, and that was extremely fulfilling for me. And as a part of that, I was able to initiate the molecular neuro-oncology lab at NIMHANS, and I am very grateful to the administration for have recognized my work and provided me the infrastructure and the space for the lab. And we used to validate, we started validating biomarkers using the tissue microarray technology.
Oh, okay.
You see, so we used to punch about 15 cases or so in a single slide, three cores per tumor, and then we had about 15 in one. So that would reduce the cost, it was very cost effective, and also standardize our results. So subsequently we started other molecular techniques over there. We started the FISH, we started PCR, conventional, real time, DNA sequencing, and slowly we started expanding that. And at one point of time we threw it open for diagnostics, you see. And we started offering molecular diagnostics for patient care, and that was really very exciting for me. And I think what we have done is, of course, by the time I retired, my junior colleague, Dr. Shilpa, she was trained by me, and she took over this lab, and now it has, I think it has progressed, and it has gone up in leaps and bounds, I can say. And they offer a lot more molecular diagnostics, they have cell culture facility and everything. So what I find very fulfilling is that started off with research, brought it down and validated it, brought it down to a pathology level, and was able to start the neuro-oncology lab and offered molecular diagnostics which is useful for patient care. So that is what made, it's a state of the art laboratory. So that was extremely fulfilling for me.
Your experience, to hear about your life's work, it's amazing, ma'am. You mentioned validating many biomarkers. Which of the newer biomarkers do you think holds the most potential in revolutionizing the patient care?
See, let me tell you, Apoorva, there is no single biomarker.
Okay.
And I don't think what we derived out of all this research is going to revolutionize patient care in the next couple of years. Maybe that's not going to happen. We, of course, we have been credited with 3 patents for the biomarkers that we have identified. But what I think is, it's the technology, you see. It is just not histomorphology, amalgamation of histomorphology with molecular diagnostics, with all the newer technological advances in molecular diagnostics, along with imaging. Imaging is very, very important, because now radio imaging has taken off in a very big way.
Yes.
And there are many groups who are now involved with radiogenomics studies, and they are trying to correlate the radiological images with the molecular profile of the tumor. I will just give you one example. IDH mutant astrocytomas, you must have heard of them. Now, one of the very classical radiological features of IDH mutant astrocytoma is a T2 flare mismatch sign, and that is now taken as a radiological surrogate for IDH mutant astrocytomas. Okay. Similarly, such surrogates are being identified in medulloblastoma molecular subgroups, several other molecular subgroups. So, imaging, histomorphology, molecular imaging, and added to that should be an AI based analysis. And that is what is going to revolutionize the diagnostic pathology over the next couple of years. It is coming in a very big way. There is no doubt about it. And I think all students should understand, they should read, they should be taught about it, and it should be included in their syllabus, and they should be updated with what is happening. Yeah, sure, in many centers it may not be possible, but that does not mean that there should not be scientific advancements. That does not mean that we should not learn about it, because it is going to revolutionize the pathology, pathological diagnosis over the next couple of years. I am very sure about that.
Yes, ma'am, definitely. So, implementation of artificial intelligence into the existing, as you said, amalgamation of molecular pathology, imaging, histomorphology, it will be wonderful to have AI's help in that.
Yes.
Very interesting conversations we've been having with ma'am here. This is the end of part 1 video. Part 2, we have more interesting conversations coming up for you. Please click on the video and watch it.